Dear students, somebody listened to the last PPT on corneal ulcer, asked me, sir, you have not even touched upon the investigations and treatment of corneal ulcer. So investigations and treatment of corneal ulcer is such a topic of its own that we chose to keep it as a separate PPT. And once you have understood what a corneal ulcer is, what is a progressive phase, what is a regressive phase, what are the infections that enter the cornea, and how come they penetrate into the cornea, which layers of the cornea get affected, and what are the complications possible if this corneal ulcer is not treated. With that insight in mind, I want you to go through the corneal investigations and treatment in corneal ulcer, which will make a huge difference, between blindness and vision for the patient. So when corneal investigations in corneal ulcer are discussed, I want you to just remember the 5 Yes. It is so very simple, the 5 Yes. One is sensation. You test corneal sensation. Okay, test sensation. Next is corneal stain. You stain the cornea. With fluorescein and see the eye in a slit lamp under cobalt blue filter. And with the staining, you can nicely see the edges of the corneal ulcer. You can measure even the how much of corneal ulcer is there. This kind of staining is very important. Next is corneal smear. You can do a corneal smear, and that we already discussed. We use a Kimura spatula, scrape the edges of the corneal ulcer, and in the microscope stain that specimen. And once you stain that specimen, you can stain it with gram stain or Giemsa stain, or you can fix it with the 10% KOH, or even with normal saline preparation. So with that, you can try to identify the bacteria, the fungi, or the acanthamoeba which is infected in the corneal scraping. Next is syringing. This is very important. You should not forget it. Even in cataract surgery and also in corneal ulcer, syringing forms an important investigation. And most of the times I see in the examination, students suffer because they just forget this simple investigation. They keep telling every other investigation, but usually the examiner will expect syringing to be the first investigation which the student offers as an answer. And if you say syringing, then it is very good. Because if you have a dacryocystitis and a septic focus, then that becomes very priority for treatment. So you'll have to remember that. Next is blood sugar. Uncontrolled blood sugar is a very big issue. Uncontrolled blood sugar is an issue where healing is not going to happen. And even if you appropriately treat the corneal ulcer, the ulcer is not going to heal. So that is about the 5 Yes of corneal ulcer. You do this 5 Yes. And of these 5, the corneal scraping is the most important. Once you have scraped properly the edges of the corneal ulcer and brought it, and under microscope you are seeing it, then you can do a gram stain. With a gram stain, you can identify bacteria. With a 10% KOH mount, you can identify fungal hyphae. With a Giemsa, you can show the cellular response. With acid-fast bacillus, you can show Mycobacterium nocardia. You can also do a calcofluor white. We discussed calcofluor white. Calcofluor white is a stain which is used for acanthamoeba. Then once you have done the staining, you can also inoculate the specimen in a culture plate and see what is the growth which is coming out of it. Once you get, usually whenever you see a corneal ulcer, you don't wait for the microbiology. You take the microbiology sample, start treatment as broad spectrum as possible, and once the microbiology result comes, you modify your treatment according to the microbiology result. That is the teaching. So if you want to wait till you isolate a fungi, then that is very bad, because by that time the corneal ulcer will become very advanced. So you start treatment initially, then wait for the fungal result to come. Once the fungal result comes, then appropriately treat with the fungi, which antifungal agent which is suitable for the fungi which you have grown. Now, what is the treatment? The treatment basically for sheet anchor. The sheet anchor of treatment of corneal ulcer is nothing but atropine. Atropine is usually referred to as A4. We refer to atropine as A4. Traditionally, atropine is referred to as A4. Atropine is a very important agent, which is a parasympatholytic agent, which is applied as an ointment or as a drop, and it is applied at least once or twice a day to all patients. This is first to rest the eye, stabilize the blood aqueous barrier, and allow the eye to heal. And it also helps in breaking the existing synapse which is present, which it also not allows new synapse to form. All these advantages are there with atropine. So atropine is a very good agent, which is in fact the first agent you will say when you are asked about treatment of corneal ulcer. Immaterial of whether it's a fungal corneal ulcer, bacterial corneal ulcer, acanthamoeba corneal ulcer, don't bother here. Whichever organism, whatever organism, treatment is initially atropine. Once you have given atropine, then choose the antibiotic or antifungal. If you are doubtful, if you think that there will be a mixed flora is where antibiotics and antifungals are needed. So the normal antibiotics used presently are moxifloxacin. Moxifloxacin is a very good antibiotic. You can use ofloxacin, gatifloxacin, tobramycin, especially in children, tobramycin is used. Antifungals, 5% natamycin, and 1% voriconazole. These are the antifungal agents. These two antifungal agents you have to remember. So once this treatment is initiated, how frequently you will apply is the important thing. You will have to load the eye with the antibiotic or antifungal. You have to apply every 5 minutes for 30 minutes, every 15 minutes for 2 hours, 1 hour for 48 hours, then 2 hours during day and 4 hours at night till healing is ensured, 4 to 6 hours till healing occurs. Especially in antifungals of the type of natamycin, very frequent instillation becomes a very important essential requirement of corneal ulcer treatment. So in the 48 hours of starting initial therapy, the treatment will be switching. If the response is not there, it will be switching to fortified antibiotics. Fortified antibiotics is where usually there will be an ophthalmic preparation of a drug, which will have a minimal concentration of the drug. The parenteral preparation of the same drug, the injection form of the same drug, will have higher concentration. So in fortified eye drops, usually we take the parenteral preparation of the drug and mix it into artificial tears or normal saline and make it into an instillable and anti-topical drug. That is the logic of creating fortified eye drops. So when fortified eye drops are used and used very frequently, then there is a good chance of the ulcer responding to this kind of treatment. Atropine we have already spoken. Then we will need to do some extra medications, give some extra medications. That is very obvious. You give some antibiotics orally or injectably, and give analgesics because there is a lot of pain. Give vitamins and multivitamins. And if the patient is diabetic, treat his diabetic state. All these we have to do. What if the patient is going for a perforation stage? If he's going for a perforation stage, what do? You ask him to not strain. There should not be any Valsalva maneuver like straining at stools, constipation, straining a prostate gland enlargement, so the patient strains for micturition. These things should not be there. If it is there, then the perforation will be more possible in these patients. You will give IOP lowering drugs. If there is a tendency to perforate, you artificially reduce the intraocular pressure by giving anti-glaucoma drugs like Diamox tablet, carbonic anhydrase inhibitor tablet. Then you give tissue adhesives. If there is a microperforation, if the descemetocele has a small perforation, then you will use glues. The glues can be cyanoacrylate glue, or a fibrin glue. Fibrin. Blood clot, no, fibrin. That same glue. Fibrin glue can be used. We can use a bandage contact lens. We can use a contact lens over the corneal ulcer, and this contact lens will not have any power. It will be of no power, zero power. but that contact lens will be used to protect the cornea, and antibiotic drops will be applied over the contact lens. So the contact lens will soak in this antibiotic solution and give it to the cornea. Amniotic membrane graft. Certain times amniotic membrane can be taken and grafted to the patients with this kind of dexamethasone. If beyond this treatment, if the corneal ulcer is going to perforate totally, then you have to do penetrating keratoplasty. In penetrating keratoplasty, which is done as a corneal transplant procedure, they'll ask you what is therapeutic penetrating keratoplasty, TPK. TKP, they call it. TKP, therapeutic keratoplasty. Therapeutic keratoplasty stands for the keratoplasty which is done in a sick cornea, like a corneal ulcer, where as a therapeutic step, you do a corneal ulcer keratoplasty in a corneal ulcer. That is called therapeutic keratoplasty or TKP. If it's a non-healing corneal ulcer, what do? You will try to re-establish the original factors which we discussed in the first slide. Is there any lid margin disease? Is there a tear film disease? Is there an uncontrolled diabetes? Is there any factors which is causing more corneal damage? That factor should be treated. Then there is a surgical maneuver possible. What is the surgical maneuver for corneal ulcer? We do a scraping. No, I told you, no, when we do a microbiology examination, we do a scraping with the Kimura spatula. That scraping with the Kimura spatula, you do more thoroughly. You try to scrape off all the edges of the corneal ulcer and the slough in the base of the corneal ulcer. This kind of removal of the most of the necrotic material in the corneal ulcer is called debridement. If you debride the corneal ulcer, it will become fresh and it will have more chances of healing. And you can also cauterize that same debrided corneal ulcer with a solution like you can use tincture iodine. You can use tincture iodine or carbolic acid, and that can be used to cauterize the ulcer. The effort to cauterize the ulcer is to use this chemical on the edge of the corneal ulcer, so that the epithelium in the edge of the corneal ulcer is harboring the microbial organism. So if you are going to destroy that by cautery, heat or chemical cautery, then that organism also is destroyed. So the corneal ulcer heals faster. So this is the overview of treatment of a normal corneal ulcer, a corneal ulcer that is about to perforate, a corneal ulcer that gets perforated, or a corneal ulcer which is non-healing. So these are the possible questions which you will usually come across in a corneal ulcer setting. We have covered corneal ulcer almost in 3 PPTs. If you saw, I want you to revise them once more and look at each point closely and remember them, so that will be very useful for you when you see such kind of patients, or more so in the examination when you are asked such kind of questions. Thank you.